I think we're going to move to the next speaker, Dr. Mohamed Zidi. He's going to talk about macro revision and complicated PDR.
Thank you, my friend. Thank you for the organizer of the MIOM for beautiful meeting. Thank you especially for Abdullah and Magdi for the kind and warm invitation. I want to share you my topic about macular revision systematically in complicated PDR surgery. For beautiful surgery, as you can see this type of result of macula independent of membrane, epiretinal membrane. Why? Because in the end of surgery, you can check the macula. And you are in front of two situations. First one, explorable or not explorable. And when you have you have the possibility to explore the macula, the OCT it's the key to diagnose some different aspects of macula, like here with the thickening of ILM, and here with epiretinal membrane for the localized vial in nasal, and of course the dissection of the macular membrane. It's very mandatory. Macular hole in diabetic retinopathy, it's the same surgery like idiopathic one, but it's different. Here the ILM can tears of many spaces, and of course it must be avoid any pinching of the retina relative to edema and exudate. And this is the result after surgery. For several cases like here with fold in macular hole and several veil in the peripheral retina, the work of course with the usually monomanually technique, like here with fold and retinal detachment. After removing the veil, you in the macula you have some this membrane, and after removing membrane you have epiretinal membrane if you want to have a relaxed macula and beautiful aspect postoperatively. In other severe cases like this with huge and large wide veil in the diabetic retinopathy, of course you can use it as you like with different technique. I use usually the monomanual one, because with the vector, the vitrector, I can do what I need, cutter and the forceps and anything. And of course you can have this final aspect of this patient. Now, when the macula is not explored preoperatively, and like here with hemorrhage, of course, the vitrectomy, when you remove hemorrhage and veil, of course, after checking the macula, you can diagnose some fold in the macula, and of course, the dissection of this fold can take at macula the final beautiful aspect. Other complicated case with the veil and retinal detachment in the posterior segment. Of course, the dissection is very hard because you have retinal detachment, and it's be careful to use this work to avoid any damage. And after this, of course, it's very important to check the macula to desiccate any ILM in this patient in the final to have this good result of this patient. And in conclusion, I can see that for a perfect and meticulous surgery, the macular revision is an obligatory procedure to have a good result. But the dissection of veil will give an anatomical result, and with PRP save the eye, and the dissection of ILM will give a functional result and save the quality of life. Thank you. Just 1 second, please, if you can. Just save the date for two congress in Morocco for the retina and for General Congress this year, next year. Thank you.
Thank you, Dr. Mohamed. As everyone knows that a fast and efficient surgeon is Dr. Zidi. So congratulations for the nice results as usual. Any comment or question from the panelists?
Thank you, doctor, for a very nice presentation. I do agree. We had a surge in macular hole after anti-VEGF injection pre-operatively. Not pre-operatively, the anti-VEGF injection in tractional cases with traction, we get a lot of macular holes, especially if a non-vitreoretinal expert is injecting. He knows we need to be conservative at this. So my question for you, if you find a macular hole in such circumstances, would you just peel the ILM or you do an inverted flap?
Independ of the size of macular hole, like the idiopathic one, and in the result of my case, what I operated, I don't find any difference between the two techniques really, because I'm between 90% of closure of the two groups when I check my patient.
This is exactly what I found. The macular holes that we find in tractional detachment, most probably because of the injection traction, which is just removal of the ILM. We do not have to inverted flap as in idiopathic macular holes, which the inverted flap increases the risk of anatomical success.
Last comment to Dr. Mohamed Zidi. I have seen in the last case that you removed the ILM at the end of the surgery and there was no macular hole, isn't it?
Exactly. In the last case, yeah.
You do recommend removal of the ILM peeling in all cases of diabetic traction retinal detachment,
No.
even if there is no holes?
No, it's two part of the response. First, I don't recommend to remove ILM for all patients. My take is to check the macula in the end of surgery, and of course, if you have OCT, for example, OCT in your microscope, it can help you to identify if you have any membrane or any contraction. And for younger people, for example, without any traction of the macula, you can do just vitrectomy for veil and laser, and it's all. But if you have any fold, any contraction of the macula, of course, if you have a macular hole, you remove ILM, of course.
Thank you.
Thank you, Dr. Mohammed. Thank you very much.